Bom, agora parece que nós estamos no ar, hein? Para as pessoas que estão assistindo de fora, então, de novo, é um enorme prazer que nós estejamos recebendo o professor Raif Geha, que é um excelente cientista e médico, e, além de tudo, um amigo muito grande que eu fiz quando fui professor em Harvard, e que eu assisti às reuniões semanais dele no laboratório. Vocês vão ver que a Cristina vai apresentá-lo, mas ele descreveu 25 genes de imunodeficiência nos últimos 10 anos. Só para vocês terem uma ideia. Em todo caso, a Cristina vai falar mais para vocês sobre ele.
Well, thank you very much, Dr. Geha, for coming to São Paulo and to meet us finally after so long. Gente, ele é eu tive essa oportunidade, como o professor Khalil falou, de trabalhar com ele há 30 anos atrás, mas tudo bem, né? Mas, então, ele me recebeu de braços abertos no laboratório dele, e o laboratório dele, então, eu trabalhei realmente na área de imunodeficiências, mas o laboratório dele envolve toda a questão da imunologia clínica. Então, ele tem uma pesquisa muito forte também, e hoje até vai falar um pouco disso, como falou também na terça-feira no Rio, sobre a parte de alergia. Então, é muito legal, é muito interessante a interação entre alergia, imunologia e imunodeficiências. Então, ele tem uma super experiência, um número inacreditável aí de publicações, como o Khalil falou também, uma descrição de genes, e tem um trabalho muito, muito interessante. Então, thank you very much, Dr. Geha, for coming. Thank you very much, Raif, for coming to Brazil and to talk to us. Thank you. Welcome.
Well, thank you very much, Professor Khalil and Christina, who finally, after 30 years, decided that she will call me in my first name. But she's not very successful. Every other time she calls me in my last name. It is a great pleasure, muito prazer, to be here. And I'm going to talk today about food allergy and about atopic dermatitis in the context of immune deficiency, which is my two interests over the years have been primary immune deficiency and allergic diseases, particularly in children. I am a pediatrician. And last couple of years, 3-4 years, we have focused on the interaction or the interface between immune deficiency and allergic diseases. So the next, I have this. This is something that most of you know, is that atopic dermatitis or eczema is the most common allergic and skin inflammatory diseases. It affects around 15% of children. And these patients make IgE antibody to food and inhaled allergen. So they develop food allergy and eventually can develop allergic asthma in what's called the atopic march. And the AD skin lesions is important to remember because I'm going to show you a mouse model, because there are studies you cannot do on human. And in this, the three characteristics are shown here. There is a thickening of the epithelial layer, of the epidermal layer. And there is also infiltration with mononuclear cells, mainly T cells, that are making cytokines, primarily IL-4 and IL-13, and there is infiltration of eosinophils. So these are the three characteristics when you see a skin lesion that define it as atopic dermatitis. Importantly, the skin also is colonized with Staph aureus, and I talked in Rio, I don't know whether any of you saw the lecture, of the relationship between Staph aureus and food allergy in atopic dermatitis, but we're not going to do that today. However, even though 99.5% of the patients that present of eczema are regular eczema, defined by the fact that they have a skin barrier defect, and I will show you how we measure it. And the skin barrier defect allows water to leave the skin, so you get a dry skin that becomes itchy. But also it allows antigen to go into the skin, which a normal skin wouldn't allow. And when the antigen goes through the skin, rather than subcutaneously or intramuscularly, it elicits a Th2 response, a response characterized by IL-4 and IL-13. So you get this permeable skin that allows antigen to get in, and you get cutaneous sensitization. However, in less than 1% of the cases, eczema is associated with immune deficiency. And there are two classes of immune deficiency where you see eczema that to the clinician is undistinguishable. It's exactly the same as regular eczema. The first group are defects in the actin cytoskeleton of the cells, and we are going to talk mostly today about DOCK8 and what it does to the structure of the cell and why does it lead to eczema. And also the second group are patients who have problem in either T regulatory cell number or function. And probably most likely many of you are familiar or have seen patients with FOXP3 deficiency. And there are many other diseases, and we will come back to that. Presumably, we didn't know that until we studied it. We presumed that the skin barrier function in these patients is normal. Why is that? Because it is very unusual to have, every time you have a DOCK8 deficiency or a Wiskott-Aldrich deficiency, to also have another gene defect that makes your skin permeable, such as the defect that's present in the regular atopic dermatitis, where many of them, for example, have mutation in the filaggrin gene, which retains the moisture of the skin. Okay? So we knew that it's really very unlikely that this eczema in these patients is due to the same mechanism as the regular eczema, which is a problem with the skin. Of course, once you get your skin, you scratch your skin and it gets inflamed, then also the barrier opens up. But I am talking about a primary defect. The defect here is primary, the defect here is secondary. So this is DOCK8 deficiency, which I will be talking about today, and you can see that they have very severe eczema, but also their eczema is tend to be very much infected, either with Staph aureus or viruses. And they also have a high incidence of food allergy. From a clinical point of view, they also have, like the patients with atopic dermatitis, high IgE and eosinophilia. But if you want a quick test to differentiate between the two, these patients uniformly have a low CD4 T cell counts. And also, they have a low T regulatory cell counts. So that simple test, if you are in doubt before you get your genetic diagnosis, is enough. What is DOCK8? Well, DOCK8 is anchored to the membrane, and in a resting cell, it binds, it has a structure that has two major domains. I'm going to focus on the second domain, because a major function of this protein is to activate the small GTPase, CDC42. In a resting cell, the CDC42 is not activated by DOCK8, but DOCK8 already exists in a complex with the Wiskott-Aldrich syndrome protein, which is present in an auto-inhibited conformation. So there is no activation going on, everything is silent. When you activate, for example, by ligating the T cell receptor, what DOCK8 is activated is phosphorylated and multiple residues, and it now allows the CDC42 GDP to become activated into CDC42 GTP, and that binds to the Wiskott-Aldrich syndrome protein that's sitting in this complex, and the Wiskott-Aldrich syndrome protein, which was in a closed conformation, opens up, and its C-terminus binds to the actin polymerization complex, which is called ARP complex of 7 proteins, and that gets the actin to polymerize and to branch. And you need the actin structure, particularly the branched actin structure, which is under the membrane, for the cell to be intact and to move well into tissues and to do its function. I am moving the cursor, not the cell. So this is what it looks like in a normal cell. You have this actin meshwork under the cell surface, And as you can see in the DOCK8 deficient T cell, as well as in this T cell coming from the Wiskott-Aldrich syndrome patients which cannot polymerize actin, so your actin assembly is bad, you don't have very good ability to cross into the tissues, that's why you get infected because you can't move. The actin network is almost gone. There is almost very little framework for the cell to use to move forward into tissues and to go and fight infection, and that's why they get recurrent infection. And the other problem, which I will address during the talk, is the issue of why do these individuals also have a problem with T regulatory cell function, as I told you. Okay. So in order to understand the disease, we compared what happened. Don't worry about this complicated slide. It can be summarized in two words, that atopic dermatitis skin and DOCK8 skin look exactly the same. Whether you look at histology, whether you look at immunofluorescence, whether you look for the presence of cytokines, they are exactly the same. You cannot distinguish them. So if you, this is the atopic dermatitis I told you about, the big epidermal thickening. It is the same in the patients with atopic with DOCK8. You can see it here. There is the mononuclear cell infiltrate compared to the normal. Exactly the same. There are eosinophils, exactly the same. And there is infiltration with CD4 cells, CD8 cells, and also with eosinophil. And the gene array, the gene expression profile is the same. But there are two major differences. The first one is that in DOCK8 deficiency, both in the blood and in the skin, there is lower number of T regulatory cell. Already they have low CD4, but the fraction of T regulatory cell among the CD4 is very low. And this is seen here. So if you enumerate the T regulatory cell, which all express FOXP3, and the other T cell, conventional cells that do not express FOXP3, and you look at the blood of the patients, and you look at their skin, and you compare it to the AD. In the AD, if anything, it's higher, the T regulatory cell. This is lower. Patients are infected, they take medications, so we always like to make sure that what we see in the patient is not secondary to the disease, it's primary. So that's why we use mice models. And we have made mice that are deficient in DOCK8, and they have the same, and they have the same thing. They have decreased T regulatory cell in the spleen, and they have T regulatory cell, lower T regulatory cell in the skin as well, and those cells express less FOXP3. So not only they are lower, they're not as robust. The second difference, which I alluded to before, is that they don't have a problem in skin barrier integrity. Whereas the atopic dermatitis regular patient, they have a damaged skin barrier. These patients, if you look at their non-inflamed skin, it is, the skin barrier function is normal. And this is, you can measure it with this device. So you can measure transepidermal water loss. This is the intact skin. It doesn't really let water go out. This is damaged skin. Somehow the cells are not really stuck well to each other. So the water can easily leave the skin. And you measure it by measuring how much water is left. And you look at patients with AD, which is in the, compared to the healthy are in blue, moderate AD in yellow, red are severe AD. If you tape strip, put a tape strip on the skin and take it out and do it 20 times, you get this curve of increased water loss in the patients, but compared to the control. The DOCK8 deficient patients and the control after 10 strippings and 20 strippings are the same, and the mice are the same. So they don't have a problem with the permeability. Their problem is different. So what is their problem? Well, one thing that is happening in these patients is that they all carry massive amount of staph aureus because they have a primary immune deficiency. They can't do a lot of, I won't go into the detail, but all of them Whereas you and I, we have some Staph aureus in 10% of the cases, 100%. And if you look at the mice and you put Staph aureus on the skin of the mice that are DOCK8 deficient, they also have difficulty clearing the Staph aureus from the skin. Although mice normally are very sensitive to, are not sensitive to Staph aureus. So we decided to take these mice and ask the question, what happened if you just put Staph aureus on the skin without damaging the skin? Just patch it on the skin, because the Staph aureus makes protease. It will eventually damage the skin and something will come in. So we put a patch that has either Staph aureus or saline, and we analyze the mice a week later. And if you look at the growth of the staph, it's okay. It's not that you get more staph. But what you get, if you are comparing the wild type mice, the normal mice that have saline versus Staph aureus, white and black, and the red and empty and the full red are the knockout, you can see that in any characteristic that you measure that is an indicator of allergic skin inflammation, these DOCK8 deficient mice respond more. So they have more transepidermal water loss increase. Baseline is normal, but it increases with both, with inflammation, but more in the DOCK8. They have more CD45, CD4 eosinophil. The only thing they don't have is that they have lower Treg cells, as I'll show you. And they have more IL-4 and IL-13 cytokines. So they develop the eczema in these mice, and probably in the humans, patients, are triggered with, is triggered by Staph aureus. So now the question is, why cannot they control that allergic skin inflammation? Because you get some in the normal mice. You just get more in these mice, that are deficient in DOCK8. Is it the Treg? So if you take normal Treg or DOCK8 deficient Treg and you put them in the DOCK8 mice, you can now compare whether their Treg are less efficient than the normal Treg in suppressing what I showed you as allergic skin inflammation. And here the blue are the mice that receive the wild type Treg, the red are the mice that receive the DOCK8 Treg. The recipient is always DOCK8 positive, so with the saline recipient there is high amount of inflammation. It's decreased in every parameter you measure by infusion of wild type Treg, but not by infusion of DOCK8 Treg. Okay? So the next thing we wanted to study in detail, why is this happening? Staph aureus is a big organism, makes a lot of genes and have a lot of things, but we had developed a model, much simpler model, and quite relevant to sensitization of humans, patients with atopic dermatitis with antigen. In this model, it's very simple. What you do is you scratch the skin, you tape strip, you take a 3M tape strip or some other disc, and you tape strip the skins 6 times, and you do it 6 times, 6 days, every other day, and then you analyze, and you either put nothing or saline on the skin, this is saline, or you put an antigen. You can use any antigen you want, it always works. You can use ovalbumin, which is the egg albumin, you can use house dust mite, you can use peanut, and at the end of the day, the end of 12 days, you get the picture I told you, histologic picture of eczema with the high TEWL and the thickening of the epidermis and all the cells and all the cytokines that you see in eczema. So this model is nice because there are a lot of reagents that we can use, and we can use transgenic mice that make, and to study the mechanism of what's happening without worrying about the staph. So if you do that and you measure what happened with the DOCK8 compared to the normal, as you would expect by now, there is, in the DOCK8 knockout, there is more inflammation, more epidermal thickness, there is more of everything, except the Treg. Okay? So this is a model that we can use now. And this model is very nice because it mimics what happened in the atopic marsh in normal mice. When you sensitize the mice on the skin and you come back later and you give them food, the same food by mouth, like the same antigen, the ovalbumin, they anaphylax. They develop food allergy. If you give it by inhalation, they develop asthma, the equivalent of asthma. So it's really a very good model. And we stumbled into this model because one of the fellows in my lab didn't want to work on something else. He wanted to work on eczema. That's how we stumbled on that about 25. You probably know Jonathan Spergel. Okay. So now what I want to show you is a little bit complicated, but bear with me for a minute. The experiment here is we wanted to know, is DOCK8 deficiency in T regulatory cell sufficient to give you that exaggerated allergic inflammation? But we faced one problem. And the problem we faced is when we made mice that are deficient, that have selective DOCK8 deficiency in T regulatory cell, they got very sick. Which really tells you that a lot of this disease is caused by T regulatory cell dysfunction. They get autoimmunity, they get skin disease, spontaneous, they lymph node become big splenomegaly, they die. So we cannot use DOCK8 mice that have selective deficiency in T regulatory cell that is constitutive, that is, you make them from the beginning. But you can get over the problem by making mice in which they look okay until you give them tamoxifen, because these mice have an inducible deletion of DOCK8 in T regulatory cell. You only remove the DOCK8 when you give them tamoxifen, because what cuts out the DOCK8 is under the control of estrogen receptor. So you give them tamoxifen and they become DOCK8 deficient. Until then, they're fine. And you can do the experiment quickly and they don't get sick. They don't lose weight, they don't get sick. So you turn it on when you want. I mean, you turn it off when you want, okay? And these mice will develop allergic skin inflammation that is exaggerated. So it is sufficient to just have the DOCK8 missing in the Treg, okay? And now we did something that looks complicated, but really is very simple. We asked the same question we asked with the Staph aureus. If we give the DOCK8 deficient mice normal Tregs, in this case, the T regulatory cells are made in such a way that they are specific to the antigen we are using, which is ovalbumin, versus a DOCK8 deficient Treg, do you suppress the inflammation? And the answer is exactly what you would predict from the Staph aureus experiment. If you give them Tregs from normal mice, you suppress the inflammation. If you give them from DOCK8 deficient mice, which is the red, you do not suppress the inflammation, okay? So that tells you whatever model you use, the Treg are important. So in summary, what's happening is that normally, you have either Staph aureus through the skin, or you have antigens through the barrier, and you get a Th2 response, but it is quite powerfully blocked. You still get a Th2 response and allergic inflammation in the skin, but it's powerfully blocked by your Tregs that are normal. If your Tregs are, if you are in DOCK8 deficiency, you have a normal skin barrier at baseline, and however, if you get some Staph aureus in, you will get exaggerated allergic inflammation because your Tregs are deficient. That causes secondarily a barrier dysfunction, and then all kinds now of antigens come get in, and you get polysensitized. But not because you have a primary defect, you have a secondary defect due to the Staph aureus triggered inflammation. These are studies that in the end of the day, this is just to get deeper into this and ask the question, why are these Tregs not working? There are two types of regulatory cells, those that go directly from the mature in the thymus, which we call natural Treg, and go to the periphery. And there are T regulatory cells that are normal cells that under the right conditions in the periphery becomes antigen-specific Tregs, and that's what we gave to the mice in the previous experiment. And you can generate them in vitro by taking naive cells. Those are not Tregs yet. You take the naive cells and you get a cocktail of stimuli, and you get what we call inducible Tregs. And if they are coming from a specific, you can make them antigen-specific. In the DOCK8 deficiency situation, there is less generation of these Tregs and less function, less ability to suppress other T cells from proliferating, conventional T cells from proliferating. So they have a problem both in the number they can generate and the quality of their function. And those inducible Tregs are important because they are antigen specific. And therefore, in the case of allergy, these are the Tregs that are important in controlling your immune response to an allergen. The natural Treg are important for controlling autoimmunity. We're not talking about that, even though those mice have also deficiency in natural Treg. Here you are talking about the T regulatory cells that you make after you see an antigen in order not to overreact to that antigen. Okay? And these Tregs are very unstable in an allergic milieu. If you put them in IL-4, they don't do very well. They have less numbers than the normal control, and they have less FOXP3 expression. And the reason for that is that FOXP3 is the transcription factor that defines what a Treg is, and that's important for Treg function. And normally it's induced by IL-2 via STAT5, the transcription factor STAT5 that binds to the DNA and allows FOXP3 to be made, whereas IL-4 counteracts this by activating STAT6, which also binds to the DNA upstream of FOXP3 and inhibit their function. So the iTregs from DOCK8 mice are very sensitive to IL-4. And therefore, in the context of an allergic milieu in the skin, where you already have a lot of IL-4 and IL-13, they become unstable. When they become unstable, they become crazy. They start making things that they should not make, including they start making IL-4 and IL-13. So instead of suppressing conventional cells from making IL-4 and IL-13, they join the band and they make more IL-4 and IL-13. Okay? And they are unstable. I'm not going to go through the detail of that. They lose their identity. They change. They become effector cells. They lose the FOXP3 when they see too much IL-4. And that's a critical issue in them, because if you take the IL-4 receptor out from the T regulatory cell of a DOCK8 deficient mouse, you control allergic inflammation. So this is the DOCK8 deficient mouse. It has an IL-4 receptor. And this is the DOCK8 deficient mouse. The Treg doesn't have an IL-4 receptor. You wipe it out genetically. And if you do that, then everything improves in the sense that your infiltration with cells, eosinophil, your Tregs go up, your IL-4 goes down, IL-13 goes down. So this IL-4 becomes lethal or detrimental to these DOCK8 deficient T cell. And that's why you get the allergic inflammation. All this is because, as we have shown in a previous publication and now in human, the IL-2 that drives the Treg formation via STAT5 is not giving the right signal in the DOCK8 deficient mice or human. If you just focus on the human, what you are looking here is you are looking at, I showed you this phosphostat5 here. You are looking at the ability of IL-2 to phosphorylate that transcription factor that drives the FOXP3. And if you look at the phosphorylation of this STAT5, it is deficient in the Tregs of the DOCK8 deficient Tregs. And you induce less, whether at 1 nanogram or 100 nanogram. And the mice is exactly the same. If you look at the dose response curve, those mice have much less STAT5. So they have a problem in STAT5 activation via IL-2. And if you put back STAT5, that's constitutively active. If you genetically put it back, then you fix everything. Everything goes down. That's the purple. Those are Tregs that now artificially you have put already active STAT5. CA stands for STAT5B, constitutively active. So every time they lose the DOCK8, they express STAT5. that is active. And if you do that, then everything gets better. So that proves that this deficiency of making STAT5, activating STAT5 via IL-2 is the cause of the instability of the Tregs that make them not work well, be sensitive to IL-4, and not control your allergic inflammation. Okay? Is that important for human? Probably. We haven't done much work, but we have given in the model here of the mice, those are normal mice, to mimic the normal, you scratch them and we put them Staph aureus. And you can do it with OVA2, and you give them low dose IL-2, you push more STAT5 formation, and things get better with all parameters. So if there is a way you can increase your STAT5 so that your Tregs are more robust, even in a wild-type mouse, you make things that are good even better, then you can control the inflammation better. I told you before that a major function of DOCK8 is to activate the small GTPase CDC42. Well, it happens that some human, very few of them, instead of missing the entire DOCK8, they have a point mutation in DOCK8. And the same point mutation can be made or found in mice. And so they have only a very surgical deficiency, very unique in that they only have one point mutation that prevent them from activating CDC42 and therefore from activating whatever downstream is on CDC42, including the Wiskott-Aldrich syndrome protein. All this slide tells you that they have the same phenotype as the total DOCK8 deficiency. But they are useful because now you have a huge molecule, 2,000 amino acids. And if you have a problem, you really don't know which part of the molecule is important. Here you know that one function is important. The rest of the functions are important. The molecule is expressed. There is no problem in expressing it. There is no problem in expressing it. They only have one problem, is that their structure is messed up and they cannot activate CDC42. And you can see that that's enough to destroy your actin cytoskeleton. Okay? And that's enough also. I showed you before that their phospho-STAT5 is deficient in the DOCK8, is not good in the total DOCK8 deficiency, and also it's not good in the point mutation. It's very poor. So they have very similar effect, okay? Including the cytoskeleton, the inability to activate phospho-STAT5 with IL-2, and they have allergic skin inflammation, okay? So it's all depend on the CD42, okay? Activation. So the question becomes very simple. Intuitively, you think that because CDC42 activates WASP, Wiskott-Aldrich syndrome protein, and because the WASP deficient cells and the WASP deficient, DOCK8 deficient cells, both have a bad cytoskeleton, and both patients and mice have eczema, that the problem is in the actin cytoskeleton, okay? That if you fix that, that everything will be okay. But that's not exactly true, because I showed you that if you destroy DOCK8 or destroy its function to activate CDC42 and therefore activate WASP, you get a problem in activating the phospho-STAT5. So you think it's maybe the actin, but this is not true for two reasons. First, if you use actin polymerization inhibitor, the phosphorylation STAT5 is completely normal. Okay, that's another inhibitor. I'm not gonna dwell into it. So, but you say, well, those are chemicals. They are not really telling me the truth about what happened in real life. And I say, yes, it is, because if you take either WASP deficient mice or humans, these are humans and these are mice, or deficient with ARP complex that's downstream of WASP, you have the same, you have totally normal phospho-STAT5. There is no problem. So this instability of these Treg cells in the DOCK8 deficiency is not due, the instability, I'm not saying that this total dysfunction, is not due to the bad actin cytoskeleton as we thought. And actually, unlike DOCK8 deficient individuals and mice, if you have WASP deficient individuals or WASP deficient or ARP deficient individual or mice, then the Treg numbers are okay. Whereas, which goes with the stability issue, okay? They have normal number of Tregs. That doesn't mean their function is okay, but number is okay. Which eventually what I am leading you to see is that in DOCK8 you have a double whammy, you have a double problem. You have bad function and you have bad stability. So numerically they are low and functionally they are not good. And the reason I say that, because if you look at allergic skin inflammation, then it is exaggerated, of course. As you know, patients with WASP, with the viscotalus syndrome, have eczema. And if you do an eczema score, it is high. It's not 0. That's their eczema score. But you can notice one thing, compared to the score in DOCK8, they are quite less severe, their eczema, okay? And the mice are the same. They develop less allergic inflammation. So they do have, but it's less severe because their Treg cells are not as badly affected. So at the end of the day, to finish about atopic dermatitis, without showing any more data, what we have come to visualize is this pattern. This is DOCK8. A major function is to activate CDC42. And CD42 activates not only WASP and ARP-C complex to get branched active skeleton, actin cytoskeleton. So if you have that part that is deficient, you get defective branching of the active cytoskeleton, which you see in these mice and human, in these mice and human, in these mice and human. All that branch gives you a defective actin cytoskeleton network. They don't have a good network. This branch is a totally different branch, but it is dependent on DOCK8 and CDC42. It goes through a kinase called PAC and phosphorylates STAT5 on a serine residue that controls its ability to be phosphorylated on the tyrosine residue. And if this branch is missing, then we have a problem phosphorylating STAT5 on the tyrosine residue, which is important for FOXP3. So you have decreased FOXP3 expression, decreased stability. So in the WASP ARP-C deficiencies, you have defective Treg function because the cells don't do a very good contact with their target. Here you have both. In the DOCK8 deficiency, you have double problem. You have a bad actin cytoskeleton, which I showed you, and you have also decreased iTreg generation and stability. And that's why the disease is more severe. But in both cases, it is not triggered by the skin defect. The eczema is triggered by Staph aureus, and that gives you allergic skin inflammation. That results in a secondary skin barrier defect. Now you get sensitization to food and environmental antigen, and you get allergen-driven eczema, food allergy, and asthma. Okay? And actually, the reason I can tell you that with some reasonable certitude is that we made mice. It was complicated, but we made mice in which this branch was intact and this branch was deficient. And we do see the problem here with the Treg generation and stability. Okay. So patients with DOCK8 deficiency develop very severe food allergy. They actually, almost half of them have food anaphylaxis. They come to the emergency room with food anaphylaxis, which is much more than you see in atopic dermatitis, who rarely come with food anaphylaxis. And if you look at their serum, they have an elevated level of serum tryptase. They have an elevated level of serum tryptase, which is a product of the mast cell compared to the normal. The normal are in blue, they are in red. And if you transplant them, the serum tryptase goes down. Now, we don't know where the serum tryptase is coming from, which kind of mast cell. There are two types of mast cell. They are connective tissue mast cell, and they are mucosal mast cell that are embedded into your lamina propria, for instance, and into your epidermal barrier. And in mice, you can distinguish between the two. So when we measured the tryptases in the mice, the one that was elevated was the MCTP1, which is the mucosal one. And the connective tissue, if anything, was on the lower side. So again, we come back, because you can't get people to anaphylax and study their, and cut their intestine and study it. So we looked at the mice, and we gave them an antigen. We sensitized them by mouse. Now, please pay attention to the blue line. The blue line is important because it's related to why children and adults, or 90% of them, do not develop food allergy. If you sensitize by mouse, you do not get food allergy. You tolerize, actually. And if you take a normal mouse, like a normal baby who is not food allergic, if you give them the food multiple times, then you challenge them with a big dose, there is no change in temperature. You're measuring the temperature here as an indicator of anaphylaxis. In contrast, the DOCK8 mice go down very quickly, 3 to 4 degrees down. They develop anaphylaxis, okay? So they are susceptible to anaphylaxis. And another indicator of anaphylaxis, other than the temperature drop, is the increase in serum MCTP1, which is tryptase coming from the mucosal mast cell. It goes up. They both develop the same amount of IgE, but these ones, one anaphylax, one do not anaphylax. This is an experiment in which, instead of sensitizing the mice with an antigen, you give them already the IgE antibody to that antigen, then you challenge them 24 hours later. You give 24 hours for the IgE to sit on the mast cell. And in this scenario of what is passive sensitization, the normal mouse will drop a little bit, and the DOCK8 mice will drop a lot. But only if your challenge is oral. If your challenge is intraperitoneal, you don't get anything, any difference. So there is something that is telling us with this experiment that the DOCK8 deficient mice are, like the human DOCK8 deficiency, are sensitive to oral challenge, and not something very specific. There is a crosstalk somehow between that immune deficiency, maybe their skin sensitization, and the gastrointestinal immune system, so that they are predisposed to have higher susceptibility only if the antigen is taken through the mouth or through the gastrointestinal tract. And actually, when we looked at the gastrointestinal tract, they had an expansion of the mast cell, but this was not present in the skin or in the lung. Only the mast cell were expanded in the intestine. And when we measure on the right side is a very important experiment, because in order to get anaphylaxis to an antigen, you have to absorb the antigen. The antigen has to go through your gut intact. If you digest it, the antibody, IgE antibody, will not recognize it anymore. So you can measure intestinal permeability by giving an antigen, in this case horseradish peroxidase, which is about the same molecular weight as ovalbumin, as many of the other allergens. And you can measure intestinal permeability, and the mice have increased intestinal permeability. And that's most likely why they anaphylax. Now, if you say, well, maybe their mast cells are strange, they are, because they don't have DOCK8, because DOCK8 is present in all hematopoietic cells. But if you take DOCK8 out of the mast cell, and only out of the mast cell, they don't have more anaphylaxis. They still anaphylax. So it's not that the DOCK8 deficiency is in the mast cell. But if your T cell is deficient in DOCK8, you get susceptibility to anaphylaxis. Okay? So the susceptibility, so that leads you to think that the T cell that's DOCK8 deficient is causing the mast cell expansion, which is allowing more antigen to be absorbed, which is allowing more anaphylaxis. And you can prove that. So first, why do they develop all this? First, we came back on some data we had generated before, is that DOCK8 deficient human T cells have impaired Th17 polarization with defective expression of IL-17, IL-22, etc. And IL-17, and they make more Th2, of course. And IL-17 is triggered our thinking because IL-17 and cytokines work on the intestinal epithelial cells. They have receptors for IL-17, IL-22. And in response to these Th17 cytokine, they make antibacterial peptides that keep your microbiome in a healthy way. So here, and what I am showing you is that the CD4 cells in the intestine of these mice, they're not sensitized as they are. They are about 8 weeks of age, 6 to 8 weeks of age, and you can see they have more of the Th2 cells and less Th17 cells. And if you look at the innate lymphoid cells, they also have more of the type 2 and less of the type 17. And as you would expect from this, the expression of IL-17 is lower, and 17A and F and 22, and 4 and 13 is higher, and this is by gene array, and this is by PCR, and they have dysbiosis. They have very significant dysbiosis. And you can see that dysbiosis not only in the globally deficient mice, but also in the mice that lack DOCK8 only in T cell. So it's the T cell that's driving the DOCK8 deficient T cell, cause you to make less Th17 cytokines, 17 and 22, you get dysbiosis. Is that related to their problem? And the answer is yes, because, and dysbiosis causes the expression, the increase in Tuft cells that are chemosensors, they sense bacterial product, and they make antibacterial peptide as well. As you can see here, they are not making very good, they have less of all these products that are products of Tuft cells, and also they are making less antimicrobial peptide. I missed that slide. So the question is, does this cascade where you have decreased 17 cytokine causing dysbiosis, causes increase in IL-25, decreased antimicrobial peptide, cause the increase in IL-4, and that drives the mast cell expansion, and that drives the intestinal permeability and the exaggerated anaphylaxis. So if that's true, if this cascade is true, then you should be able to correct it by intervening at each step. First, if you intervene by administering Th17 cytokine, you correct the problem. I'm going to only focus here on the temperature drop. You improve the temperature drop. You improve many other things. If you give them antibiotics, a mixture of antibiotics to fix their dysbiosis, you also improve everything that you want to improve, including the temperature drop and the IL-4 drops and the IL-25 drops, as you would expect from the cascade. Then you give them anti-IL-25, you drop the IL-4, you drop the temperature is better, and you give them anti-IL-4, and the temperature is better, and you also drop the IL-4 via a loop. So that tells us that this cascade is real. And the question, why is the IL-4 making them susceptible? In the gut, the two major things that work with IL-4 are mast cells and T regulatory cells that are being modulated by IL-4. So we looked at the mast cell, and yes, indeed, if your mast cell do not have, if you make a DOCK8 mice that doesn't have IL-4 receptor on the mast cell, you also improve the situation, and you also improve the intestinal permeability. So the IL-4 is working on the mast cell. And if you look at, is it working on the Treg? If you look first at the DOCK8 mice, they have a very interesting finding related to the issue of dysbiosis and control. And this is, if you look at their Treg cells in the gut, like in the spleen, like in the skin, their Treg cells are lower. And there are several types, and their FOXP3 is lower. And there are several types, subtypes of Treg cells. the most important one that control mast cell expansion and dysbiosis is the ROR gamma T. They express the transcription factor ROR gamma T. They are the equivalent of 17 cells. And those are the equivalent of Th2 cells. But these are subsets of T regulatory cells. Those are high and those are low. And this ROR gamma T also is important for crosstalks with the suppressor factor TGF beta 1. And they have less TGF beta 1, but they have normal IL-10. So they have an abnormal landscape of T regulatory cells. And their T regulatory cells, without going into the detail, if you put wild-type cells with mast cells in vitro, and you get them, ask the mast cell to fire after you put IgE complexes on its surface, the T regulatory cell will suppress this phenomenon, and the T regulatory cells that are DOCK8 deficient do not. So that is a potential link between the T regulatory cell and the mast cell. As I showed you before in the skin, that the T regulatory cells are unstable in IL-4. So we use the same mice here. They have a deletion of IL-4 receptor in the T regulatory cell in a DOCK8 deficient mice. And if you look at this situation, then everything is improving. The T regulatory cell number now are okay. They have more of ROR gamma T cell, and they make TGF, more TGF beta 1, and more importantly, if you remove the IL-4 receptor from the Treg, you improve the anaphylaxis. So, in summary, what's happening is that you have decreased Th2 Th17 cytokine in the gut, and you get intestinal dysbiosis that drives an increase in tuft cells and an increase of IL-25s, which acts on T cells to make them more Th2 cells, and that make more IL-4, and that IL-4 paralyzes the ROR gamma T cells and also act on mast cells, and the double whammy acting on mast cells, you get increased antigen absorption, which then the rest is cut, which results to more increase in anaphylaxis because you absorb much more antigen, and also you have more mast cells as well. And they make more IgE antibody in the real active immunization situation. I mean, these are the people in the lab who did the work, and people who collaborated with us for the microbiome studies and provided the reagents with and the TMP and mice. Thank you.
Question.
Hi, my name is Leonardo. I work with autoinflammatory disease, so I work more with the branch of the... I'm sorry, it's not me, it's there. Aumenta o volume, por favor. Can you hear that now? Yes, okay. So I work more with the branch of the genes that start the cytoskeletal formation. The cytoskeletal formation, the PST-PP1 gene, the CDC42, and the MEF gene, the pyrin gene, they start the cytoskeletal formation. So I'm always curious about that because, as you said, you think that the cytoskeleton is not related with the DOCK8 deficiency. So it's not more...
I lost you a little bit. Which genes are you working on?
Autoinflammatory genes, PST-PP1, CDC42, and MEF pyrin gene.
Yeah.
So usually they start the cytoskeletal formation, and the consequence of it is the DOCK8 activation and the VASP protein activation. So it's because we have a paper published that we treated a patient with PST-PP1 mutated patient. We treated her with anti-L1, and we observed the formation of FOXP3 protein after the treatment. So we think that the cause, this is not a cause, it's the consequence of the innate immune activation. So I was thinking about that. What do you think that about this related to your study, like studying the more the innate immunity as a initial starting point of the disease?
Well, I think that you said when you treated her, the FOXP3 went up.
Yes.
Yeah. T regulatory cells normal are not only unstable in IL-4, but they are also unstable in IL-6 and interferon, gamma. So probably if you had innate cell activation, you only did not have, if you had high IL-1, I am sure you had high IL-6, and that may have made her T regulatory cell unstable, and by giving less FOXP3 expression, and maybe by interrupting that circuit, because IL-1 induces IL-6, as you well know. So I won't be surprised that she has high IL-6. That may have improved her Treg FOXP3 expression and the Treg function.
Okay, and the second question is, do you think that the gene therapy that has been developed by Rosa Baqueta for the FOXP3?
I think you're talking too close.
Sorry, can you hear now?
No, I think you're getting this one too close, maybe a little.
Yeah, but this one, I think it's not working very well. Okay. Can
Not
you hear
too
now?
close, not too close.
Not too close. Do you think that the gene therapy that is being developed by Rosa Baqueta for the FOXP3, I mean, restoring the FOXP3 with the gene therapy would also work for the DOCK deficiency?
It's not a matter of restoring it here because it's not mutated. It's not mutated. So if you want to restore it to work at that level, you are going to have either additional copies of FOXP3 or do what we did, which is take the FOXP3, one copy, and make a copy that's constitutively active. And we don't do that. It's much easier to fix the DOCK or just give them a bone marrow transplant. They do very well with bone marrow. They do very well with bone marrow transplant. We transplanted the first case back about 15 years ago, and they do very well. We have to go early. We have to transplant them before they get very sick.
Okay, thank you.
Yes, Magda.
Thank you so much for such a wonderful.
Thank you.
I am very particularly interested in autoimmunity. How is autoimmune diseases are not so high among
Very good question. The question is, why is autoimmunity not high among the DOCK patients? I told you something important to that question. If you take the DOCK from Treg cell, they develop massive autoimmunity. What protects them is that their effector cells are not good. So that protects them. If you have normal effector cell, but your Tregs are only one that are abnormal, missing the DOCK, you develop massive autoimmunity. That's what's called the silver lining.
Professor Geha, thank you for the excellent. Thank you. So, Professor Geha, thank you for the excellent talk. From your interventions in the DOCK mouse, would any of them translate into therapy for atopic dermatitis patients?
Yes. Yes. Not all those patients are. Have good donors. So some of them we cannot transplant them. So if you give, even if you take the older mice and you give them dupilumab, you will improve. You will decrease their mast cell load in the case of food allergy, and you will decrease their allergic skin inflammation. And actually, this experiment has been done in a human. There are case reports about eczema. There are not case reports yet about food allergy.
Any other questions?
Considering that Th1 cells also express FOXP3 during activation, how do you exclude the role of Th1 cells in your model? Because the mice were full knockout for DOCK8, or FOXP3 dependent deficient for DOCK8, right? So how do you exclude that Th1 cells were not suppressing the Th2 or playing a role in controlling the microbiota and everything else?
I mean, first, the expression of FOXP3 in Th1 cell is very minimal. Second, we had all these adaptive transfer experiment, as well as a reconstitution experiment with the Treg cells. Is it raining? So I think we can pretty well exclude that. Do DOCK8? Neutrophil have some functions. Yes, they do. Surprising. The reason they get all this staph infection is because the neutrophil do not go into the tissue. You need a good actin cytoskeleton to go into the tissue. So, surprisingly, we thought at the beginning that the major reason might be that they're not making IL-17, because IL-17 is very important for staph. But the reason it's important for staph is because it makes the chemokines that bring in neutrophil. And that was normal in the skin, because their gamma delta cells in the skin, which are the major source of IL-17, were making normal IL-17, unlike the T helper cells. The gamma delta cells were making normal IL-17. And the reason I showed you the mice pictured where I didn't go in detail, but they keep on having trouble clearing the staph. Eventually they clear it because mice are not sensitive to Staph aureus. The reason for that, if you look at their skin, the infiltration of neutrophil is very much affected, whereas all the 17 chemokines are perfectly normal, but they can't get them in. Another secondary defect, you also need a good actin cup to engulf the bacteria, and both the Wiskott-Aldrich syndrome patients and DOCK8 deficient patients cannot make a good actin cup, because that depends on the subcortical branched actin cytoskeleton. There should be an easier way for the three-dimensionally impaired people than these devices.
So if there's no more questions, I'd like to thank Raif Geha again for coming to São Paulo and give this beautiful talk. And we are now going to the lab. If someone else wants to talk to him, he'll stay for a short time there. Thank you. Congratulations.